Hi, my name is Kathy Kennett. I'm Senior Vice President of Clinical Care for Parent Project Muscular Dystrophy. Welcome to our webinar today entitled Orthopedic Complications in Duchenne. This webinar will last approximately 60 minutes. All audience members are on mute. If you do have a question, please type it in the box in the lower left side of your screen, and if possible, we'll save all the questions for the end of the webinar. This webinar, as well as the questions and answers, will be archived on the PPMD website. I'd now like to introduce our speakers. Dr. Susan Apkon has over 20 years of experience in neuromuscular care and is currently the Director of Physical Medicine and Rehabilitation at Seattle Children's Hospital. In addition, she's the Director of the Neuromuscular Program and is engaged in care and research focused on optimizing strength, range of motion, function, and performance. Cary has worked as a pediatric physical therapist her entire career. She's worked in many different areas of pediatric PT, but has always been involved in the care and treatment of muscle diseases. Terri is currently involved with numerous clinical trials for Duchenne and SMA and is excited about the research around emerging novel treatment options and is passionate about finding ways to help this amazing group of patients. Dr. James McCarthy is Professor, Department of Orthopedic Surgery at the University of Cincinnati and is Director of Pediatric Orthopedic Surgery, Alvin Crawford Chair in Pediatric Orthopedics at Cincinnati Children's Hospital Medical Center. Dr. McCarthy's primary clinical and research focus is on the treatment of pediatric hip disorders, complex limb and spine deformities, and scoliosis, as well as gait analysis in children with neuromuscular disorders. Dr. Apkon?
Great. Thanks, Kathy. I'm going to jump right in. As Kathy said, we're going to be talking today about orthopedic complications in boys with Duchenne muscular dystrophy. The areas that we're going to discuss today involve both the evaluation and treatment of common orthopedic complications and include three. We're going to talk first about contractures. We're then going to talk about scoliosis. And finally, we'll end with a discussion about fractures. To start, I want to just define a contracture. What I'm referring to is the loss of joint flexibility or range of motion. Contracture can occur at any joint in the body, but most commonly in boys with Duchenne dystrophy occurs in the ankle. The degree of contracture or loss of flexibility can increase over time, and it can also increase in terms of the number of joints that are involved. Now, preventing a contracture can be very, very difficult, but what I'm going to suggest is that we ought to try to prevent it as best as we can. Contractures in boys with Duchenne muscular dystrophy is caused by weakness to a large degree. It's also biomechanical in another way, and what I mean by that is for boys who are up walking, the contracture at the ankle or those toes in a down position can actually help with some of the walking. Contractures change over time, and it really depends on the stage that the boy's in. So a boy who is walking may only have contractures or limited range of motion in the ankles, but as they get older, it can involve the elbows, shoulders, and hands. When we evaluate range of motion or when we evaluate a boy for contractures, we do that in the clinic setting, and that should be done really at every muscle clinic visit. It may not be obvious to a parent or the child that we're doing it. We may be just a parent to wiggle the ankle or the hip or the knee, but we're actually looking for the range of motion. Depending on the setting, range of motion may be evaluated by a physical therapist or it may be by one of your physicians. In between your muscle clinic visits, if you have a physical therapist in the community, she or he can also be monitoring that range of motion. All joints should be assessed, including the shoulders, elbows, wrists, and fingers, as well as the hips, knees, and ankles. Again, we know that as boys get older and are relying on a wheelchair longer term, their arms may be more involved. So in our little boys, I may not focus so much on the assessment of range of motion in their upper limbs. These pictures just give you an idea of how we actually evaluate, and you can see the slide on the left is looking at the different ranges at the ankle. In the up position is called dorsiflexion, and that can be quite tight. The down position is called plantar flexion. The slide on the slide on your right actually looks at inversion and eversion, the foot going in or out. And that's especially important for kids as they get older because oftentimes that foot develops a contracture in the in position. And so if we try to stretch them in the out position or eversion, it can be very limited. Treatment options vary. I like to suggest a proactive approach. So in other words, we want to evaluate and treat before a contracture actually develops, before it's really an issue. You could also see a reactive approach, so that once the contracture has developed, then we may get aggressive. One thing I want to point out is that the approaches to contracture management, or limitations in range of motion, are very different when we treat a boy with Duchenne dystrophy or any child with a neuromuscular problem versus a child with, say, cerebral palsy. Kids with cerebral palsy have increased tone, and so the option may look very different. So in a child with cerebral palsy, I might offer something called botulinum toxin, or you may know it as Botox. That's a very effective treatment for contractures in children with cerebral palsy because of their high muscle tone, but something we absolutely don't recommend in boys with Duchenne dystrophy because it's a very different problem, a muscle weakness problem. So Botox is not appropriate in that group. There are two ways to approach the treatment: non-surgical, which Terry's going to start by talking about, and then the surgical approach, which Dr. McCarthy will talk about in a little bit.
So for physical therapy, that's also a treatment for contractures. This can involve stretching and positioning, bracing, serial casting, and therapy. Next slide, please. For stretching and positioning, it's important to maintain the range of motion and symmetry because this can maximize function, reduce the risk of fixed deformity, and prevent pressure sores. Again, all of these are important things that we need to do for a lifelong basis. The need for stretching doesn't stop. Once the child goes into a wheelchair, it just changes a little bit. Your physical therapy should develop an individual program for your child. The muscles that your child needs to be stretched might differ from another boy of the same age, and it's going to differ from another child of another age. So make sure that your physical therapist or physician develops a program for you. You are very lucky because the PPM website has a wonderful resources available in a PDF and DVD by Helen Posselt, who's an Australian physical therapist. There's pictures, you'll see some of those in a few minutes, that give you really good ideas and suggestions that can augment what your physical therapist is showing you. Next slide, please. So which muscles should I stretch? So as Dr. Apkon talked about a few minutes ago, your ankles are the first muscles that get tight, and this prevails throughout. Your knees or hamstrings are the other muscle group that tends to get tight early on. The secondary muscle groups that get tight tend to be your hip, and here we're talking about the tensor fascia lata or iliotibial band. And in the secondary contractures in your ankle will involve the posterior tibialis, a different muscle in your ankle. And lastly, mostly in the non-ambulatory stages, wrist, elbows, and fingers tend to get tight, and these are important so you can maintain function for driving your wheelchair and for being able to do some self-feeding and maintain the active position that you'd like to have. Next slide, please. Some helpful hints for stretching. These are always helpful. It's always best to do stretching when your muscles are warm. A cold muscle doesn't respond as well, and it also can be more painful. It's important to make these a part of your daily routine, just like brushing your teeth or eating lunch. If you have stretching as part of your daily routine, you're more likely to do it. Consistency is key. This is a theme. You're going to hear this over and over throughout my talk. But you want to make sure that you're doing them on a consistent basis. That's more important than how you're doing it. Really doing them on a regular basis is key. Weekly school or community physical therapy is not enough. Daily or 5 times a week is really something that's going to be more important for you. Next slide. These pictures are from the website. This is just showing an example of passive stretching. Next slide. Sometimes you might want to use a wedge for positioning. You can stand on the wedge, and that will give you a nice heel cord stretch. For hip flexor stretching, laying on your stomach over a wedge can be a really nice way to passively stretch that muscle group as well. Next slide. So self-stretching is done by the child themselves. Some boys do really well with this technique, and others really don't do as well. They don't ever really get a good stretch because they're not putting their muscles in a good position, and they may need to just have passive stretching. Next slide. Again, as the boy progresses and gets older and becomes non-ambulatory, upper extremity stretching is going to be important. And this just shows some elbow stretching. Next slide. Positioning. Sitting and wheelchair positioning, is critical to reduce contractures and development and reduce the risk of scoliosis. We probably won't be able to eliminate it, but if we can reduce it, that's always helpful. Management of asymmetries in all stages is critical. Asymmetries is where you have some muscle tightness that might be tighter on one side of the body than on the other side. And this can lead to increased falls and can also contribute to the development of scoliosis. Next slide, please. So proper positioning helps. I think the slide probably speaks for itself, but you can see the boy on the right certainly has better positioning in his wheelchair, is showing less contracture development. The boys on the left have developed contractures, possibly due to poor positioning, and also this is what's an inevitability at later stages. Next slide, please. This is an example. This is a really nice chair. This chair allows the boy to stand up, and it gives a nice stretch to both the hip flexors, knees, as well as ankles. Gives you all of those at once, and it also allows the child to stand up and be at the same level as their peers. Unfortunately, these are expensive and sometimes hard to get funded, but if you have the opportunity, they provide a lot of adjuncts to other therapies. Next slide, please. Bracing. The use of night splints has been shown to decrease contractures. Again, consistent use is key. Sylvia Hyde, in an article in Neuromuscular Disorders in 2000, showed that the consistent use of night splints with stretching can lead to significant decreases in contractures. This study was also found to be true as part of Tina Dong's poster presentation that compiled info from the Synergy study and the DMD natural history study that also showed that time function tests are actually faster. This is the 10-meter walk, getting up from the floor, going up and down stairs, that these are actually faster with better range of motion. Next slide, please. So to increase compliance on use of night splints, this is always an issue. Sometimes sticker charts or reward charts can be helpful. Gradually increasing use. If the child doesn't tolerate using them all night at first, maybe a couple of hours at a time or part of the night, and then increasing use can be helpful. Alternating nights, starting with one night right, the other night left. Sometimes that can be helpful to increase compliance, especially if they have trouble moving in bed. And sometimes daytime use, when the child is sitting doing homework, playing video games, or watching TV, that can also be helpful. Next slide, please. Daytime AFO, and again, an AFO is an ankle-foot orthoses. We generally avoid these in use in ambulatory boys, and this has been found to have increased falling, and also it increases the demand on the quadriceps. This was shown in an article by Stevens in the Journal of Prosthetics and Orthotics that it not only gives the demand on the quadriceps, but it increases the eccentric contractions of that muscle, and that's something we know that we want to try to avoid. They can be helpful, however, in non-ambulatory boys for wheelchair positioning. Now, daytime AFOs, or ankle-foot orthoses, may be helpful in some select situations. These need to be determined and monitored by your physician or physical therapist or both, so you make sure that if you are using a daytime AFO, they're doing what they're supposed to do and you're not getting any harmful repercussions. So there's a lot of questions now about using a flexible toe-off brace. This has an anterior component that the other bracing doesn't have. And there was a really nice article recently done by Elise Townsend in Pediatric Physical Therapy that was just published this year that showed that these braces, this is a small pilot study, but they slowed walking and increased falls. Again, this is a small study and more research into this needs to be done, but the preliminary tests were not promising. Next slide, please. So this is just a slide showing some examples of the type of braces that are used. On the left, a Cascade Dayfo number 9 is probably the most commonly prescribed brace for early and young boys. It has some stretching straps that are commonly used. A solid ankle AFO is in the middle position. These are used for children that need them for wheelchair positioning, and also this might be the type for ambulatory boys that are used in select patients. The Kitty Gate is an example of the toe-off brace, and again, so far the evidence has not been shown to be helpful for boys with Duchenne. Next slide, please. So knee, ankle, foot orthoses, or KAFOs as they're commonly referred to, these are rarely used now in the United States. They were probably 20 years ago, but now they're not used often. Outside of the U.S., they may be used to help prolong ambulation in some situations. They may prolong walking and standing after multiple tendon lengthenings. However, the caveat with this is that walking speed is slowed. Stairs become more difficult, and they might need to use a walker to walk, and so this may increase the risk of falling. Next slide, please. This is just a picture showing you what KAFO looks like. And next slide, please. This is an example of a resting hand splint. These are often custom made by occupational therapists. They may be off the shelf, but this is used to prevent or control contractures of the hands and wrists. Next slide, please. So serial casting is another way to help control contractures, and this is a series of casts that are applied to the ankle with the goal of improving range of motion in a short period of time, and involves frequent cast changes. These are not consistently performed in all centers, and this is just something that's starting to be used. These need to be done only for select patients, and Alan Glantzman, in his article in Pediatric PT in 2011, has some nice guidelines for who this might be appropriate for. Next slide, please. The length of time that the child is in a cast and how often these cast changes are done varies a lot from site to site. Some sites are doing them 2 cast changes a week for 2 weeks. Some are doing weekly, and in some they're even leaving the cast on for 2 weeks at a time. Again, the most important thing for this is that whoever's doing the casting understands not only how to do the casting, that's certainly important, but they also understand Duchenne. This is totally different from the kind of casting that we do for cerebral palsy, so it's something that we want to make sure that we are having this monitored. Next slide, please. This is just an example of what the position would be for serial casting. Next slide. And Dr. McCarthy, you're up.
Great, thank you. Thank you, Susan and Terry, and also Kathy for organizing this. And I just want to start by saying a couple things. One, I very much agree with the approach that's been outlined. Taking a proactive approach is a huge benefit, because if we can prevent any kind of surgical intervention, I think everyone's going to be happy at the end of the day. And the nighttime splitting is quite effective for maintaining range of motion, but doesn't seem to gain range of motion. So all those tenets I agree with. The second issue is that surgery is never a pleasant experience, even under the best of circumstances. And so anything we can do to avoid that is important. And I think the final thing is, anytime you consider surgical intervention, it really is something that that has to be driven by the patient and the family. And we obviously spend a lot of time also working with our physical therapists to make sure this seems to be the right decision. At this point, there's very little data and or clinical studies either supporting or negating the effects of this. But I'll go over some of that information for you. In general, when we think of contractures, there are really 3 reasons we consider surgery. Overall, it has to be refractory to non-surgical methods. But in general, in higher functioning kids, better position of the foot for gait and stance would be one indication. Those are children typically in our setting undergo gait analysis before and afterwards. Better foot position for standing and transfers. Those are children who are already non-ambulatory. And better foot position in wheelchair and shoe wear. Now, anecdotally, probably the patient population where it's not very effective for are those that are marginal ambulators, because any intervention, any small perturbation can decrease ambulatory ability, and so we have to be very careful with that population. So there are some studies, and these are very old studies now. They're 2 and 3 decades old, which looked at releases prolonging ambulation, and they typically underwent multi-level releases, so bigger releases, including the hip and iliotibial band, and often put them in KAFOs. So I'm not sure this really applies that well to today's world, but it did show that there was at least some evidence you could prolong ambulation, and of course this was before the use of steroids. Today, really the primary focus is on the foot, so I've never put a child in a KFO. I know that they've done that in Europe and other places. I don't personally know of North American surgeons putting people in KFOs, except for very rare circumstances. So the focus is primarily on the foot. I typically no longer perform heel cord lengthening or in very rare incidents, so I'll tend to do that lengthening higher. And the reason I do so, it's just a safer place for a lot of reasons. You don't risk healing issues or over elongation at the ankle. And I'll show a picture of how that looks. So this is a diagram taken out of a textbook, and it's essentially where we lengthen, it's above the heel cord. So you never fully sever the heel cord. You lengthen the tendon, and then the muscle below will stretch up to about 3 or 4 centimeters. It will not go beyond that. So for really, really contracted feet, for someone who's non-ambulatory, then we may actually do true heel cord lengthening, typically combined with other soft tissues as needed to get the foot in good position. But for ambulators, we virtually never do a heel cord lengthening. Postoperative care is important, and we're really modifying what we're doing even more recently. So absolutely weight bearing immediately. If they can be up that day, I'm happy. If not, certainly the next day. It can be uncomfortable. So the child shouldn't be concerned if they don't necessarily want to walk immediately, but we do strongly encourage getting up as soon as possible. We've usually, in the past, used short leg casts for up to 6 weeks, and that's fine if someone is functionally very strong. If they're not, even the weight of a cast, which may only be a pound or so, can be too much. So now we're moving much more quickly to braces, even within a couple of weeks. So a cast for a week or two to main position, and then going into a brace. And then long term, once you obtain the position you want, then we like to maintain that using nighttime splinting. And that's all I have on contractures. I think with that, we're going back to Susan for scoliosis.
Great, thanks. I think we'll move on, and I think Kathy is kind of keeping track of the questions, and so we'll have lots of time at the end to answer questions. I can see some of the questions that people have about when to start using orthoses and things like that, and we'll be able to talk about that. What I'd like to transition to is talking a little bit about scoliosis. Scoliosis refers to a side-to-side curve of the spine. Frequently, we see it as a big C-shaped, but also can be seen as more of an S shape. So a C shape at the top and then a reverse C on the bottom, or vice versa. When I think about kids with scoliosis, I think about a typical teenage girl who has what's called an idiopathic scoliosis. What's unique about those girls is once they stop growing, usually that curve stops getting worse. What we're referring to here, though, for boys with DMD, is something called a neuromuscular scoliosis. And this is very different. It's caused by weakness, not idiopathic, which means we don't really understand it, or maybe a genetic cause. So this is really caused by weakness, and the progression is very different. In other words, it can continue to progress even after boys go through puberty. The picture on the left is a relatively straight spine of a boy, and that's something that we would follow on exam or by x-ray. But the curve on the left, you can see all the way down at the bottom, this gentle C-shaped curve. Generally, in boys with Duchenne dystrophy, we think about scoliosis developing after they stop walking. So we worry most about it when boys are in early adolescence or mid-adolescence, when they start using a wheelchair full-time. There are some cases, although much less commonly, of boys developing scoliosis when they're still walking. Fortunately, the most severe of scoliosis has really decreased pretty markedly. There are several studies that I listed below that showed boys using corticosteroids, so either prednisone or flagocort, have much less of a risk of having a progressive severe scoliosis requiring a surgery. So not only do corticosteroids help with walking, but and heart and lung function, they also help keep the spine straight. When we evaluate a child for scoliosis, the first thing we do is a clinical assessment. So when the kids are standing, we'll oftentimes have them lean forward, and you'll see us run our hand down the bones of the back. That's an easy way to look for a scoliosis. And this should occur at every visit at all ages when boys are walking. Once a boy stops walking, then we recommend yearly x-ray evaluations. sometimes it's really hard to see a scoliosis underneath the skin. I sort of say to the kids, I don't have x-ray vision, and so we need to get an x-ray so we can really see. Especially if the child has increased fat, it's really hard, and scoliosis can be well hidden underneath that fat.
Susan, would you be able to speak a little more into the phone? I had a few people just message me that it's hard to hear you. I just didn't know if you wanted to speak or not. That's perfect.
Sure. So what we typically do is a clinical assessment at each visit in our boys who are still walking, and that's having them bend forward and us looking at the straightness or the curviness of the spine. Once a boy stops walking, the current recommendations from the 2009-2010 CARE guidelines recommend an annual evaluation for curves under 20 degrees. But if a curve is identified that's greater than 20 degrees, then we should be looking at that curve by X-ray every 6 months. The treatment of scoliosis, similar to the treatment of contractures, is non-surgical and also surgical. And so we'll have Terri and Dr. McCarthy talk about those options.
So we talked a little bit before about wheelchair positioning, and it looks like, I'm not sure where the music is coming from, but I hope you all can't hear that. But wheelchair positioning, it's important that the seat should fit well. Again, all of these are important because wheelchair positioning can help eliminate some of the risk of scoliosis, not all but some. The seat should fit well. It should provide a stable base, but it still should allow for maximum function. That's one of the things I think that's very important. You don't want to strap them in so much that they can't move, and then they're going to lose function at the risk of contracture. There are many options for seating, and these are really too many to actually list, but your therapist and your seating specialist can help you with these. There are many custom features, again, that can be used to help control posture, and evaluation of the pelvic obliquity or the angle of your pelvis, hip abduction, your hips moving apart, and resting posture all can be very important in evaluating how your child is sitting in the chair and what will be needed. Next slide, please. Use of a seating specialist. In some places this is an occupational therapist, in others it's a physical therapist, and other it may be someone totally different. But it's important to find someone that knows seating and that you also have an experienced vendor that knows Duchenne muscular dystrophy. Again, the seating for this diagnosis is a lot different than it is for some of the other diagnoses that we see. Unfortunately, insurance may often dictate exactly what kind of wheelchair you may get and what the extent of custom options that are available, but working with your families and your providers can hopefully help with this. Wheelchair positioning should be monitored frequently due to growth and function changes. Even within 6 months, there can be huge changes that can occur that need to be taken into consideration to help get that proper positioning. Next slide, please. So when you're preparing for spinal surgery, so the scoliosis there, and now you know that you're going to have the surgery, it's really important to plan ahead to get all the equipment that you need before you have surgery. These are sometimes hard to obtain, so you may need a mechanical lift or a hospital bed or possibly a rolling commode seat. You might not have needed those before surgery, but this may be something that the surgery is going to bring to mind a little more rapidly. It's also important that you practice before surgery with the therapist on how to roll, on how to lift to both minimize the pain involved post-op and also to prevent caregiver injury, because you're going to do this a little bit differently than you did prior to surgery. Next slide, please. And this is just a picture. A Hoyer lift might be something that you need. If you were lifting your child by yourself in a one-person almost scoop lift, that might be painful for your child after, and using a Hoyer lift might make it a lot more comfortable for them. The rolling commode chair on the right is also something that might be helpful. If lifting them onto the toilet is hard, rolling this over the toilet might make things more helpful. Next slide, please. And again, Dr. McCarthy, back to you.
Yeah. Thanks very much, Terri. And I think Terri is going to talk a little bit about the post-op PT then after I talk a little bit about surgery. Notice that we never really mentioned much about bracing. We know that in idiopathic scoliosis, like Susan mentioned, a very different process, bracing actually is effective. It decreases the chance of progression and or the need for surgery. That data really isn't there supporting supporting neuromuscular curves. And I'm not saying that there might not be indications for it, but we talk very little bit about it because we don't think that's going to prevent this curve. It's also very different than how we treated Duchenne's before steroids. It was very, very common that it's for the curve to progress very quickly as soon as they stop walking. So a 20-degree curve quickly would be 40 and 60. And it was so much harder to treat those bigger curves that this is one of the times that we were really fairly aggressive in treating scoliosis, even with a smaller curve. Now, much of that has changed, and in fact, we rarely have to perform surgery on kids with Duchenne's because of use of steroids. What you see here in X-ray is fairly quick progression of the curve. In a child, it's just as Susan already described it. It's typically a lower lumbar curve and progresses fairly quickly over time. If it gets to the point of surgery typically is fairly effective, and we tend to fuse the entire spine. So we start up at the very top, the upper thoracic spine, just below the neck, and typically we'll fuse either to the lowest vertebrae or to the sacrum, depending on how oblique the pelvis is. Now, there's advantages to fusing less in that you gain more motion, and I think as everyone on the phone call knows that the motion of the spine, even though it's not enormous, actually is often used by kids with Duchenne's for functional purposes. So you can lose function, and it's important to think about that ahead of time, as Terri was talking about, and understand that there are benefits to it, but there may be some downsides, and you want to anticipate those ahead of time. So it's a long fusion. What you really want to do is make the spine solid, and you use instrumentation, but it's not the rods that really do anything. They just hold things in place until the spine itself autofuses. Once it autofuses, and that's a very solid construct, it's not going to deteriorate after that. In general, despite the fact that it's a big surgery, it is really fairly effective at correcting the curve. And the way it's done, it takes a while because the bone quality isn't quite as good, and we use something called segmental fixation, which is probably more important from a surgical standpoint than it is from a patient or therapeutic standpoint. And the type of instrumentation has changed over time, but the process is really the same. The good news is when you go through all that, there are high rates of fusion and correction. So in generally, if it's a 40-degree curve on average, which is about what it starts with, you usually get it to less than 20 degrees. And 20 degrees is what's noticeable clinically. Rarely are there problems with pseudoarthrosis, neurologic problems, or damage. So especially when you catch these curves a little bit earlier, the surgery itself goes relatively routinely. There are medical issues, and we have to be well aware of that. And my only recommendation would be if this surgery is to be undertaken, I would do it at a place where they have some familiarity with Duchenne's and know how to treat these kids. And also, some of the functional scores tend to be a little bit better, pulmonary functional scores a little bit better post-op than pre-op, but the overall deterioration doesn't change. In other words, the disease progresses regardless of whether or not you have surgery. This is just an example. I apologize for the poor quality of a child sitting with about a 40-degree curve, and that's what it would look like, and then before and after surgery. This is why people don't want to do it, other than the pain, is that there are always complications, and it's a big surgery. Infection is the most common. Many institutions now have very strict protocols to try to decrease infection rate. They're called surgical site infection bundles, and they do everything they can to decrease the rate. And this has been really quite effective at decreasing infection rates from about the 1 to 5% to the under 1% mark. Hyperthermia needs to be understood that it's a risk and be managed, as well as some of the cardiac issues. So you need a strong cardiac team. And because of the nature of the disorder, blood loss can be more common, so that has to be prepared for. And if needed, surgery needs to be terminated if blood loss gets to be too much. So with that, I'll go back to Terri to talk about post-op surgical management, PT management.
All right. So the post-surgery management of scoliosis surgery will vary a lot from hospital to hospital. And this isn't something that the physical therapist is necessarily going to dictate. This is something that's usually dictated by the surgeon, the type of procedure that was actually done, and what the hospital protocols are. Typically, the goal is to get up in a chair as soon as possible. In our facility, this actually happens the first day after surgery. In others, it may be a little bit different, but upright sitting is very helpful in preventing pulmonary complications. Lungs expand a lot better when they're in upright position, so everyone's going to be pushing hard to get, even when you think this is crazy that they're getting up so soon, but this is something that is going to be a big push. Sometimes a two-person lift or use of a mechanical lift may be necessary, even if that's not something, again, that you did before surgery. It's something that might be helpful now to reduce the pain and also to make it just easier for both you and your child. Next slide, please. Sometimes, and like Dr. McCarthy mentioned a few minutes ago, there can be increased difficulty with independent self-feeding after surgery, and this is because the fusion doesn't allow you to bring your head down to your hand like the child did before. So sometimes you may need a higher surface or even mobile arm supports, and I'll show you a picture of those in a second. This may be helpful after surgery, and just being aware that this doesn't necessarily at all indicate that the child is weaker, it's just that their biomechanics have changed. Home physical therapy for a short time may also be needed or useful to help the family practice with those transfers and to address any new issues that may come up post-surgery. Next slide. This is just an example of a mobile arm support. Again, it's supporting the arm, uses levers and balance to allow them to be able to bring their hand to their mouth again. Next slide. And I think this goes back to Dr. Apkon.
It does. I'm going to start transitioning from scoliosis now. Our final topic is going to be fractures. And what I mean by a fracture is a break in the bone, most commonly in the leg. Unfortunately, it is common in boys with Duchenne dystrophy. There have been reports of upwards of 40+% of boys at some point will have a fracture. It can occur with minimal to even no trauma, interestingly, and so it may occur with a transfer, a slight movement, and that's all it takes. It can also be a little bit more trauma, like a fall out of a wheelchair or a fall when walking. It's more frequent in boys who are non-ambulatory. There's several reasons why boys with DMD have fractures. Muscle weakness is a primary reason. Bones get strong by a strong pull of the muscle on them. When you don't have that strong muscle pull, it can lead to decreased bone density or osteopenia. Limited weight bearing also. So kids develop increased bone density through running and jumping. If you are a boy with Duchenne and aren't able to run and jump, or you become non-ambulatory, then that can lead to increasing problems with osteopenia or decreased bone density. Corticosteroids are a big culprit, and most of the kids are on it at some point during their lives, and corticosteroids are known to decrease bone density. When I list nutritional deficiency, what I'm primarily referring to is vitamin D. Vitamin D helps absorb calcium in the stomach, and if you don't have enough vitamin D, the calcium doesn't get absorbed, and again, you have decreased bone density. And finally, delayed puberty. So boys accrue bone as they go through puberty. If you have delayed puberty because of the corticosteroids, the deflazacort or the prednisone, then you could have decreased bone density or osteopenia because of that. The current recommendation is to monitor bone health through vitamin D levels, which are obtained annually. In places like Seattle, where I live, and where there's a lack of sunshine, I oftentimes will recommend doing it every 6 months if the numbers are low. We do DEXA scanning, and that's just a fancy X-ray that allows us to quantify the amount of bone density in the spine or the hips or the distal femur, which is the part of the femur right above the knee joint. The recommendation is to do a DEXA scan at baseline or at the start of steroids, and then every 1 to 2 years. Now, even as I say that, I sort of cringe a little bit, and the reason I cringe is that there's really not at this point a consistent standard. So if you go to 10 muscle clinics across the country, you'll have 10 different evaluation recommendations. The work of Kathy Kinnett and others at PPMD to have PPMD Duchenne certified clinics is really an attempt to help us to all standardize so that we're all doing things to help to improve the overall health of boys with DMD. Lateral spine films are also helpful if we're looking at signs of low bone density or something called compression fractures. It's a lot easier to pick it up when it's a side view than a front view. When a fracture has been identified, we want to manage it in several different ways. One, we want to make sure that the boy is well treated for pain. And it's fine to use things like Tylenol or Motrin, but when you have a broken bone, it oftentimes can be quite painful. And so the use of narcotics is frequently used. The people in the emergency department or if a child is seen in a primary care office may have a little bit of hesitation with the use of narcotics like oxycodone or morphine, but in fact kids tolerate it very well at reasonable doses and should be considered. If a surgical intervention is recommended, then it's very important beforehand to make sure your cardiologist and pulmonologists are involved. And I'm speaking more about the older boys, boys who are wheelchair dependent, boys who might have signs of restrictive lung disease, maybe on BiPAP, or kids who have obstructive sleep apnea, or boys who might have signs, even early signs of heart involvement. We want to make sure cardiology and pulmonary is aware before the child goes under anesthesia. We also want to monitor the respiratory and the mental status closely. When I say mental status, what I mean is alertness, orientation, do they know where they are, who they are, kind of what they're doing. And the reason for that is there's a very serious complication, but incredibly rare, called fat emboli syndrome. Fat emboli syndrome occurs after a fracture or significant trauma to a lower limb. The fat from the bone can travel through the bloodstream and go to the lungs and brain, which can cause some confusion, shortness of breath. It can lead to a rash, fever, low platelet count, and a fast heart rate. So lots of symptoms can be associated with it. A fast heart rate in itself in a child who's having pain with a fracture is not suggestive of fat emboli syndrome. It's really the shortness of breath, the change in mental status that worries us. Kathy, can you go ahead and advance the slide? Kathy, can you advance the slide?
Yes. Kathy, are you having trouble with, I know it's going back and forth.
Oh, no. I'm on 57. So, Sue, can you see fat emboli syndrome, the treatment?
No, it's not advancing for me.
Okay. You are.
That's okay. I can wing it. So the treatment of fat emboli syndrome is really focused on the early recognition of it. So being in a center that will recognize that shortness of breath could be a sign of this fat emboli syndrome. Early treatment also can be the use of oxygen to support it. Interestingly, corticosteroids can be used, and really stabilization of the fracture with a surgical intervention if necessary. It's important to know that it's incredibly rare, and also the vast majority of kids who or adults who have fat emboli syndrome recover very well. Other treatments include bisphosphonates. So bisphosphonates, examples of that might be alendronate or pamidronate. You might know it as Fosamax. Is a bisphosphonate which helps to decrease the osteoclast activity. So osteoclasts are the bone cells that the cells that break down bone. Bisphosphonates can help decrease that process. There's a lot of, again, sort of question about whether or not we should just treat it before it happens or before there's a fracture. That's called prophylactic treatment versus doing it reactively after a fracture happens. Most centers don't treat prophylactically, and the reason is that the medications, the bisphosphonates, are not entirely benign medications. We also know that almost all boys, even ambulatory boys, will have decrease in bone density by DEXA, and so treating the numbers oftentimes makes people a little uncomfortable. I think over this next year or two, we'll have a much better idea of the consensus and how we should move forward. I think most would agree, though, that after a fracture, the use of the bisphosphonate can be very helpful at reducing the risk of subsequent ones.
Great. Thanks, Susan. So I just have a quick slide on orthopedic treatment of fractures. This isn't always understood. So unfortunately, when your child or your patient has a fracture, they'll go to the nearest location for care, and that orthopedic surgeon may have a lot of experience, or they may have very little experience with Duchenne's. And one of the big issues for ambulatory boys is that the goal is to get them up and moving as soon as possible. So in general, a good surgeon will take the most conservative approach to fracture treatment, which is often splinting, bracing, or casting. This is an exception. This is a time when you want to be a little bit more aggressive, and if you can, provide a construct that will allow weight bearing as soon as possible. So it's a little different approach, and patients, families, therapists all need to be aware of this because they may have to educate the surgeon or go to an institution that has some experience with this treatment. And then in rare cases, we'll supplement with bracing as needed, but the goal is to get the boys up and moving as soon as possible in ambulatory children. If they're non-ambulatory boys, then splinting or bracing may be very effective. Then the goal is a little different. It's to prevent deformity and to make sure that the child is comfortable, and immediate weight bearing isn't as important. And I think now Terry's going to talk about some of the therapy post-fracture.
So just like Dr. McCarthy, we are reiterating each other's points, but early mobilization is essential, and it involves a team effort. This might not be something that's comfortable, just like post-surgery. It might not be something that's comfortable for the child after surgery, but certainly is important to get started right away. And educating the family, the clinical staff, and possibly the school on safe transfers, especially if the child has a cast. And this might be a child that's in a cast in a wheelchair. It might be a child that's ambulatory. If they don't have a cast, still, safe transfers are going to be ultimately very important. My favorite form of rehab after a fracture is swimming, and that needs to be after. If they've had surgery, the incision has to be fully healed, and the rehab physician needs to, or rehab or orthopedic surgeon needs to say when this is appropriate. Next slide, please. And this is just a picture of a child, actually a young man, swimming as a form of therapy. And I think that is our last slide, and I think we're ready to open it up for questions. Thank you.
Thank you all so much. This has been really, really helpful. We do have a couple of questions, and I'm going to try to put several of them together. So if you feel that your question isn't being answered, then just type it in the little box, and I'll make sure we ask it. So for Terri, first of all, when would you suggest beginning a stretching program and starting to use AFOs? And how long should a stretching program take?
So I always recommend stretching at the very first visit. Some centers will do this after the child starts to show some signs of contracture, but we can talk a little bit the same that Dr. Apkon did about the fact that being proactive rather than reactive is always important. I'd rather start the habit before there's issues. So I always recommend stretching at the very first visit. And night splints, it's kind of the same philosophy. Some centers are doing it after the child gets tight. But again, if you can start to establish a habit before there's an issue, that's really the most important. And the stretching program shouldn't take very long at all. I think 20 minutes, again, some families will do it twice a day, some will do it once a day. Depends on how willing your child is to hold still for the stretching. But this shouldn't be a very lengthy process at all. And if you're doing the stretching for them, if they're distracted while you're doing it, I think it's actually helpful. They can be watching a video or TV or listening to music while you're doing the stretches. If they're not participating, you might be able to get a more effective stretch. Thanks.
Thanks. Sue, could you maybe speak to the impact of or the importance of AFOs after loss of ambulation?
Yeah, I think from my standpoint, again, most families have done a really great job doing the stretching early on when the kids are walking, and also keeping them in their resting night splints. Once a boy stops walking and they're wheelchair dependent, they're at really high risk for to lose more range of motion. And then you've probably all seen boys whose feet are sort of turned in, and as they sit on a footrest, it's almost the side or almost sometimes the top of the foot that's actually resting. And for that reason, again, I like to be proactive. So if a child will tolerate wearing orthotics during the day while they're in a wheelchair, that's a great option. Or at night continue to use the resting night splints. But I wouldn't abandon ship, so I wouldn't just stop everything once a boy stops walking or is walking, much less. At that point, I think it's just as important to maintain that range of motion, because I think your overall position in a wheelchair is going to be so much better if the feet can lie flat on the footrest versus on its side. The other issue, which young men tell me about, is they want to wear cool shoes. And if the foot is in the turned-in position, it's really hard to put a cool shoe on. And so I think that actually is an important piece to think about and a really good reason to continue to wear either daytime braces or nighttime resting night splints.
Thanks. There are a couple of questions about the toe-off AFO and one question about the carbon fiber AFOs to walk in. The first question about the child with the toe-off AFO walking with a walker. Now the mom is a little bit concerned. Are there recommendations that you would make, Terri?
Again, the study that was done was a very small pilot study, and a carbon fiber and toe-off brace are relatively the same thing. It's a lightweight brace. So I would think you need, especially just to work closely with your physician and your physical therapist. If it's working for you and it's not causing any problems, then I don't think it's a big issue. If they're walking with a walker, then that might be something that's helpful for your child. It really depends on why they were put in one in the first place and if it's working and if it's not causing any problems. It's hard for me to say without, being there what's going on, but I think your physical therapist and your physician can be really helpful in providing the answers to that.
One additional comment I would make is I had read that comment, and I had comment talked about knee hyperextension. In boys with Duchenne, the quadricep muscle, which is your thigh muscle, can be very weak. So locking your knee into extension can actually keep you upright. By taking that away, it actually can make walking harder. So, at first glance, if you see someone hyperextending, we sort of say, ooh, we want to avoid that. But in fact, it actually may be beneficial to boys with DMD. Terri, would you?
I echo that entirely.
Okay, I just want to make sure you agreed and I wasn't.
No, I totally agree.
Well, I think that, just to add to that, that's one of the reasons why we're so nervous about overlengthening the heel cords, because then that causes this collapse and this loss of plantar flexion extension response. So I agree with that, and it's an important consideration in treating these kids.
Jim, you could probably answer this question as well. So is there any, if guys' feet are turned in, is there anything that can be done?
Yeah, so it's not that the surgery is necessarily technically difficult to get them in a more neutral position. It's, what are the benefits? And typically the therapists and the families are the ones that talk to me a little bit more about that. If a standing program is very important and there's insignificant quantum of errors, then that can be a problem for standing or wearing shoes or sitting in the wheelchair. And how much of an issue that is, in my view, is varied a little bit from family to family. So it's not that it can't be done. Is it worth it? And for some reason, children with Duchenne's tend to have more pain and discomfort after surgery. It's a bigger deal, even though the surgery technically isn't that much more difficult than it might be a child with cerebral palsy. So I don't know if it's so much technically can it be done. It's just in the long run, is it helpful?
So really it's just a risk versus benefit.
I think primarily. Now, there are some really significant contractures and poor bone quality that might be more of a challenge, but it's really much more risk. That's correct.
Okay. There's a question about SMOs with a fully ambulatory child. Should it be continued? But I think that must be KFOs.
No, they probably are talking about SMOs, so just a foot orthotic. Dr. Apkon, you can chime in on this as well. Those I think are fine. It just depends, as long as they're not limiting the motion, and they wouldn't be because it doesn't go over the ankle. A lot of children will have some issues with their arch, and they're going to be flat-footed, and supporting that might be helpful, especially for a short period of time. Dr. Apkon, do you want to comment?
I totally agree. I think that you made a nice point earlier that every child's individual. And so if a child is having a little side-to-side instability or weakness, then a short brace, we call it a SMAFO, which stands for supramalleolar or just above the ankle brace, can provide a little bit of additional support, sort of like a high top. Just gives a little extra support, and it's not going to limit them getting up on their toes. It's not going to limit that knee extension if they need that knee extension. So if it works for an individual child, I'm supportive.
Okay, thanks. Terri, there's a question regarding resources for the prevention or maintenance of hand-arm contractures and strength. And where to find resources. I think you spoke to that on the webinar.
Oh, goodness. So an occupational therapist would probably be a lot better for commenting on this, but I can't off the top of my head comment on resources available. We don't actually have an OT that's in our clinic on a regular basis, but I don't know of any articles that would be most helpful, but I think that the research all shows that they get tight and that they need to be supported. But as far as actual functional things, I think we're still really working on this. That we're now just doing more functional outcome measures, and I think we'll have more data as far as how to predict this. But for right now, I'm not aware of any particular studies. Anyone else?
I am not either.
Okay. All right. So I think there's this question about is Botox safe to do for the foot, and I think we discussed on the webinar that Botox is not safe to do in Duchenne.
That's correct. Botox is not. It's not necessary. It's not going to help. It actually could weaken the muscle. But the way that Botox works is it actually weakens the muscle. And if you already have a weak muscle and you add a medicine that weakens it even more, it can be a real problem. So I would not recommend at all a boy with Duchenne having Botox in their muscles.
And Sue, there's a question about how long should boys take steroids or should patients take steroids. Do you want to talk about that for a minute?
Sure. I mean, it's a little bit beyond this conversation, but in general, historically, when kids were put on steroids, they were used to help kids to walk longer. And then once they stopped walking, then they would stop steroids. We would wean them off slowly, but we would stop the steroids. I think at least at this point, I think most would agree that the long-term use of steroids is important. There's nice studies that show that long-term steroids help with heart function and lung function. It helps keep spine straight. And so at least in our practice and most of the practices that I'm aware of, long-term those boys stay on the steroids.
Jim, did you want to say anything about that as well?
No, not other than I agree. It's made a huge difference from our standpoint.
Okay. I think that's all the questions, unless I've missed something.
Do we have a minute for one question that I could ask? I'd be very interested in Terri and Susan's input. How important is it to get a non-ambulatory child and to maintain them in a standing program?
So that varies a lot from site to site. It depends on, I think, the family goals. If the family's goals are to keep them up and standing and they're not opposed to using equipment for that, that might mean using a KFO or using a standing frame. And those are really difficult to get the child into. So I think that that's one of the drawbacks. But if that's something that the family really is hoping for, then I think it's important. As far as what the impact that has on bone density, I'll let Dr. Apkon speak to that.
Yeah, I agree with Terri. I mean, I think it's we talk about the parents, but I think it we're also talking about the young men's sort of preference. If we can keep someone standing, I think it's great. We don't have evidence, at least evidence that I'm aware of, that standing, those boys who have stood longer have better bone density. So an 18-year-old who's still in a stander or in a standing wheelchair we just don't know if they have better bone density. But what I could say is that flexibility at the hips, knees, and ankles is something that we would expect to see longer term with standing. And so I think that if a family or a young man would like to stay standing, I think using a stander is a great option. I'm a big proponent of the standing wheelchairs. They're very difficult to get approved. I'm happy to write a letter of appeal or two, but many insurance companies won't pay for that feature. But if we can get it, then I go for that as well.
Well, good. That's very helpful. Thank you.
Sue, there's one more question that may be beyond the scope of this webinar, but regarding bisphosphonates and DEXAs. DEXA scores are often improved with the use of bisphosphonates, but are there studies or have there been studies done that indicate whether that means that the bone is stronger or that the bone is denser?
Yeah, it's the million-dollar question, and I think that there's some evidence in the adult postmenopausal women population that the bones actually may have a different quality to it. And actually, the postmenopausal women may have fractures that are not typically seen in those who aren't on bisphosphonates. And so I don't think that we have the evidence yet in kids. What I think we want to know is if we improve bone density by using bisphosphonates, does the fracture decrease? And I don't think we have enough robust data at this point to sort of make that statement.
Thank you. I would totally agree with that. I think we're about out of time. So
can I make just one quick comment? I just wanted to give a quick shout out to the 16 centers that I surveyed, that responded to my survey, that responded to help me get a better idea of what a consensus as far as physical therapy and some of the centers that are treating a lot of patients with Duchenne muscular dystrophy. So if you happen to be listening and you participated, thank you, thank you.
Thank you so much, and thank you to all the presenters. We truly appreciate your time and your expertise, and this has been invaluable.
Hi, and this is Ryan, everyone. I know a few questions came in that were unable to be answered. I'm logging those, and we will get you answers directly, we promise. Okay, thank you, everybody.
You bet. Take care. Thanks so much.
Thanks.
Bye-bye. Thanks.